Hi, everyone. Welcome back to another virtual morning report. We're so happy to have Dr. Conan Liu be here with us today for a second round of Clinical Reasoning VMR. I'll pass the mic to Dr. Liu to just say hi, and then to our case presenter, Yusuf.
Oh, sure. Thanks for having me on again, you guys. My name's Conan Liu. I am a third year hospitalist at UC Davis. This is my second time on Virtual Morning Report. Looking forward to a challenging case, and we'll see how I do. I definitely feel like some of my idols, like Yusuf and Ravi and all those people, are way above my level, but I'll definitely try my best with what I can try on this case.
No, Conan, that's way too kind. That's way too kind of you. Conan, what has been like the highlight of your like past 2 weeks?
I actually was just in Atlanta visiting family. I just got back yesterday, so really fun time. We basically did an early Christmas, so we gave a bunch of presents to the kids and everything. So it was a lot of fun.
Oh, that's great. Hi everyone. I'm Youssef. I'm also a hospitalist. Really happy to be here. I have a really fun case for you, Conan. Also, if you're gonna do great, and this is a really hard case, and like even sometimes like you will see you'll go through it. It's really fun, so it'll be good. So whenever you're ready, we can go ahead and get started.
Yeah, we
Yeah, that
can
sounds
start.
good.
We can also, I just thank you, Lyra and Siva, for helping us with describing and teaching points. We can start now.
Yeah. So I have a 35-year-old female, no past medical history, presenting for 10 days of abdominal pain, swelling, a few episodes of nausea, few episodes of diarrhea, and 3 kilogram weight loss over the past month. She also reports intermittent night sweats. And I'll stop there.
Yeah, perfect. So this is not really the most typical patient we would get with a young woman with no medical history. But whenever you see something that comes in where they have no prior medical history, I find it's always a case that something potentially very interesting might be going on. And you also have to take it very seriously because this is not a typical patient who comes in with pneumonia all the time, like very frequently to the ED. Usually in a young patient, their threshold to go to the ED is very, very high. And so they must be feeling very poorly in order to want to come, seek attention for this. And then the 10 days of abdominal pain, it's starting to get into that kind of subacute time frame of symptoms. But then also we have some red flag symptoms with the weight loss and night sweats. So those are definitely things I'm going to be paying attention to. And then with abdominal pain, of course, with the clinical problem solvers, we have kind of that diagnostic schema for abdominal pain. So you kind of think about your intra-abdominal or intra-intestinal processes. Then you have your extra-abdominal organs. For example, maybe their kidney or their ovaries or something outside. Maybe even pneumonia could cause abdominal pain. And then after that, you have imaging negative causes. And then the most important one is actually the first thing you need to look at is life-threatening causes or any emergency causes of abdominal pain. So yeah, I'm looking forward to seeing how this case develops.
Sounds great. I'll give you some more information that you can go off of. So the patient lives with her spouse, doesn't have any like smoking or drinking history, works as a male woman, does not take any medications. She's originally from Mexico, currently lives in Atlanta, Georgia, where you just were. Uh, and then it comes to our evaluation on exam. In general, she's not in acute distress. Her heart and lung exams were normal. And then you notice that her abdomen is actually distended. She's non-tender, and she has a positive fluid wave. No rashes were noted. You don't see any like spider angiomata or anything like that. You have a normal neurologic exam, and then you find an ultrasound machine, and you just do a POCUS, and you do see some ascites. On initial labs, the hemoglobin was slightly low, with 11.3, with a normal MCV, platelet count of 387. And then on chemistries, kidney function was normal, liver enzymes were normal, bilirubin was normal, INR was within normal limits, PTT was normal, and an HIV screen was negative. And would love to hear from you about like your thoughts, and do you think this is cirrhosis? Do you not think this is cirrhosis? What would you do next? And especially because I'm sure you see this a lot, and I know that you're a proceduralist too.
Yes, yes. So, uh, we do wonder if this is cirrhosis sometimes, but you very clearly pointed out, kind of in the physical exam, that we don't have any clear signs of stigmata of cirrhosis. So typically, if somebody has cirrhosis, you're going to be looking for those spider angiomas, maybe palmar erythema, and some other signs in males. You might see gynecomastia. So the fact that she doesn't have any of those signs kind of suggests that she may have a non-portal hypertensive etiology to her cirrhosis. Also, in a 35-year-old, it's definitely possible to have very severe cirrhosis, but typically you're going to start seeing that in older patients. Like at 35 years old, it'd be pretty young for just severe cirrhosis. And we also didn't have any history of her drinking a lot of alcohol or any other reason for her to have cirrhosis. I think one of the things, and whoever's writing this here is highlighting it, but the fact that she's from Mexico, anytime in a morning report, but anytime you see a patient who's immigrated from an endemic area, you have to think about tuberculosis. Tuberculosis can pretty much present in any sort of way. It can really do whatever it wants. So of course, we always think about pulmonary manifestations of tuberculosis, but I've seen many cases of abdominal tuberculosis, and it could very easily cause ascites. And it would also kind of fit with the weight loss and night sweats. And then the hemoglobin of 11.3 is just kind of borderline low, but it does suggest that potentially this process may have been going on for a little bit longer than maybe just a week or so. Um, because sometimes you'll see people start to get some anemia of chronic disease if things are more ongoing. I'd be interested to see what her albumin is, kind of albumin kind of being like a negative acute phase reactant. So sometimes you'll see like a low albumin if somebody has this chronic process going on. Um, and yeah, so definitely in any case where you have new onset ascites, all of these patients warrant a tap right away. And what are the things we're going to be looking for? We're going to be looking at the SAG. So is it less than 1.1 or greater than 1.1? If I were just to guess in this case, I would, because I'm thinking it's a non-portal hypertensive etiology, I'd be thinking of a SAG of less than 1.1. And then you also throw on the protein studies. We also would just throw on the gram stain and the fluid cultures just to make sure there's no infection that's also ongoing here. But if we are considering TB, some of the additional tests that they sometimes send for, I believe, are like AFP, LDH. There's another one that I'm not. I think there's a few more other ones that I would definitely be looking up to make sure we're not missing TB in this case.
That's great. That's a really, really great discussion. And does the negative like lung exam or uh, sway you away from TB, or would you still consider it at this juncture?
I would still definitely consider it because we can have TB that's not manifesting in the lungs. Of course, like I mentioned, we always think about pulmonary TB, but it can be isolated outside of the lung and have extra pulmonary manifestations without lung involvement.
Yeah, that's great. I'm gonna give you the information you asked for. So the patient comes in, gets an ultrasound of the abdomen initially, like a formal ultrasound that shows a moderate volume ascites and a left lower quadrant cystic lesion, possibly arising from the left adnexa, so a left adnexal lesion, and then gets a CT abdomen pelvis with contrast, which shows large volume ascites, prominent celiac, ileocholic nodes, and then nodular peritoneal thickening with a, again, the 6.2 centimeters left ovarian cystic lesion that is noted. And then the findings were commented in the read that says findings are concerning for peritoneal carcinomatosis and omental caking. And then patient does end up getting a paracentesis. The acidic albumin was 2.9, uh, while the serum albumin was 3.6. So the SAG was less than 1.1. The acidic protein was 5.5, so it was not low. There was 1,900 white blood cells. The polymorphonuclear cells, the PMNs, were less than 250, so they were 95. And the rest were lymphocytes, so 1,700 lymphocytes. And I'm going to pause there as like if you see a trainee with you and you have this patient, what would you want next? What would you think about? And what would next?
Yeah. So the SAG was less than 1.1, as we kind of expected. And that is a really high white blood cell count, but thankfully it sounds like it was the PMNs were less than 250, so we don't have any signs of spontaneous bacterial peritonitis. But the lymphocytes being very high definitely increases the concern for some kind of atypical infections, can cause high lymphocytic predominance in acidic fluid. And again, TB could be one of those causes of a high lymphocyte count in ascites. When we look at the radiology read, they are already calling this, it sounded like they were saying this is already peritoneal carcinomatosis. They already thought it was suggestive of malignancy. I think that's definitely still on the differential, but TB could also cause a lot of kind of granulomas and infiltrates that could look like a omental caking kind of picture as well. And then we talk about this large left lower quadrant or left ovarian cystic lesion. Um, I'd also be curious to see if that is involved, if this is part of the same process or is this a separate process? Is it potentially an incidental finding? My gut feeling is that it's probably involved in whatever's going on here. And when I hear about like ovarian masses and ascites, one of the other things that kind of pops up on my mind is there's that MEGS syndrome, which I think was with the like granulosa theca tumors, and they have this very thick ascites fluid that comes out. It doesn't sound like that's it doesn't sound like that was the description that we have here, but that's definitely something I'm thinking of as well in at this stage.
Awesome. So I'll give you some more info. So some serum markers were sent for cancer. So CA-125 was sent, and it was high at markedly high at 573. The AFP, CA, and beta HCG were normal. The ascites TB PCR that was sent off the fluid was negative. The fluid was sent for AFB culture and adenosine deaminase, and those are cooking. And GYN was consulted, and they were like, there's some concern for ovarian cancer given this cystic lesion, like you mentioned. And then other non-TB testing, non-acidic testing includes an interferon gamma release assay, so a quant gold, and that was positive. Ended up getting a CT chest. So the CT chest was normal, got a sputum AFB times 3, which was negative, and a TB PCR of the sputum that was also negative. And I would love to hear your thoughts, A, on like what you think, and B is like how do you approach uncertainty? How do you communicate it with the patient? Because this patient is in a really tough spot, and how do you teach about like uncertainty and how do you communicate?
Yeah, yeah. So first of all, just going through the labs that came back, and I agree, this is a very challenging case. So uh, the CA-125, classically we associate that with ovarian cancers, but actually it can be very nonspecific as well, and it can be elevated for all sorts of other reasons. And basically, any intra-abdominal pathology can cause your CA-125 to be high. So in that sense, I can't hang my hat on the CA-125 saying this is ovarian cancer. But I am glad, they got OB and OBGYN involved because I do think that it still is on the differential. But I think really the pertinent thing here that we need to do is rule out TB first. And then, we can start going down the ovarian cancer pathway after that. But like I mentioned, the CA-125 can be very specific, non-specific, so potentially not that helpful here. With the TB workup, the peritoneal TB fluid PCR being negative, I would have to look into the sensitivity and specificity of that exam to see if it's possible it could be a false negative. Her interferon gamma release assay was positive. Generally, we don't like to use like Quant Gold or like PPD screens. Those are more indicated for latent TB testing because they have pretty high sensitivity and specificity for latent TB. But if somebody has active TB, actually the sensitivity and specificity drops to like 60 or 70%. So they're not as helpful in the setting of active TB. In this case, it was positive, so that might again be making us think, okay, maybe it is TB still. The sputum AFB still pending. So the TB PCR is negative. The TB PCR, in my understanding, is pretty sensitive and it comes back pretty quick. Um, but the sputum AFB is the one that we track over like several weeks, and that one is kind of like our gold standard. It's like a lot more sensitive. But again, those two are kind of for pulmonary TB. In this case, she didn't really have any pulmonary symptoms because I'm assuming the TB PCR was also from the sputum, and then the sputum AFB were from sputum. So, um, yeah, in communicating uncertainty to the patient, I mean, I would just be really honest with her that, I think we kind of have two different possibilities that could be at play here. I think one of the things we're worried about here is tuberculosis. And so we are going to be doing all the testing required to see if that's what's going on. But there is still a chance that this could be some kind of tumor. And so that's why we're doing this further workup and basically letting her know that we're going to kind of keep her updated every step of the way. And if it is TB, we could start her on treatment. So, kind of if I were to pick one, maybe TB would be more treatable potentially, but yeah, just kind of letting her know where we're at. We're not sure if this is TB versus ovarian cancer versus something else, but we're in the process.
Yeah, no, that's great. And I have maybe one more aliquot, and then we can like reveal diagnosis and then chat about it. So, and then Conan, before I give you the information, what would you do next?
Yeah, well, I would definitely have my ID colleagues already involved at this point. Um, and the thing is, I would wonder again, I'd have to look into the sensitivity and specificity of the PCR testing for TB because my gut feeling, I guess, just that base rate of disease. This patient's from Mexico. They have this kind of subacute illness that, 10 days of symptoms, it did happen pretty quickly. Um, I just feel like the base rate of disease, TB, is kind of highest here. Although it very well still could be ovarian cancer. So I would involve my ID colleagues, see what else we could do to help work this up or finalize whether this is TB or not. And then if that's all negative, then we would go after maybe that ovarian cyst. And the thing with ovarian cysts is usually you don't want to biopsy any ovarian cysts because if you're concerned for a malignant process it's one of the tumors that could spread. The other one being testicular cancer is also one that we don't like to, biopsy. You just kind of do orchiectomy to just kind of remove it. And the reason that I think about it like that is because, those cells are ovarian cells, when they release eggs and then when your sperm are kind of moving around, they're programmed to travel to different places. So if you stick a needle in them, if there is any malignant cell in there, like testicular cancer, those cells are already pre-programmed to like try to spread everywhere. And so there's a really high risk of it seeding to other places. And then the other one that we don't really like to biopsy sometimes is kidneys. But I think sometimes that's more of like a bleeding risk than anything. But a lot of times we'll just go straight for nephrectomy if there's a concern for a kidney cancer also. Um, so yeah, I talked to my ID colleagues, try to figure out if we can finalize the diagnosis, and if not, then we would talk to the OB colleagues and see if we need to do a removal of that cyst just to make sure it's not a cancer.
Yeah, that's great. And the reason I said the case was hard is because it requires multidisciplinary care, and it's like it needs more than one team that like to think about this case, and instead of just like one person who can figure it all out. So
Right.
I'll give you some more information. So like you mentioned, ID was consulted, and they said, okay, at this point, we're definitely have latent TB, and if we're gonna consider cancer, this would need to be treated regardless before any chemotherapy is initiated in the future. Let's maybe try to sample the peritoneal lesions. So interventional radiology was consulted, and they did perform some peritoneal sampling. In the meantime, some blood tests, some tests started to come back. So the cytology of the ascites was negative. And then the team was thinking, what if this could be like a GI malignancy that's metastasizing there? And I know somebody put in the chat, AMK put in the chat, it's like, oh, what if there's like a GI malignancy? Uh, GI was also consulted. They did an EGD that was within normal limits. And at this point, a lot of the tests were pending. So the patient was discharged and like this portion of uncertainty. And then she represented.
You gonna go home?
Sorry,
Yeah.
let me and then represented 3 weeks later with worsening ascites. And then at this point, you're also the hospitalist taking care of this patient. You open the pathology. At this point, the pathology started coming back. So you see a path that shows non-caseating granuloma from that biopsy. And the AFB from the biopsy are still negative. So you consult surgery, and surgery actually do a laparoscopy. And on the laparoscopy, they see like miliary nodularity all over the peritoneum and omental caking with adhesions. And more tests are coming back. So the ascites AFB actually remains negative. The adenosine deaminase sample is actually lost, so we never get the result just as like in process, which is like real life. And then at this point, we get like repeat abdominal imaging, and the ovarian cyst is no longer noted on the repeat CT scan. So there was like some cyst there, but it's no longer noted on the repeat imaging. And then biopsy from the surgery. So surgery, as they do surgery laparoscopy, they sample some of these lesions. And the pathology comes back as non-caseating granulomas, caseating granulomas. The cytology is negative. The AFB stains are negative, and AFB cultures are collected. And so I'm gonna pause there. The next aliquot does reveal the diagnosis, but would love to hear.
Yeah, this is a very interesting case, and lots of twists going back and forth. That I think a lot of us were surprised that the ovarian cyst kind of just disappeared all of a sudden. Um, so when we talk about the granulomas, I think getting the peritoneal lesion biopsy was very helpful. So obviously, we classically learn like caseating granulomas or necrotizing granulomas are associated with like TB, and then non-caseating granulomas often we can see with kind of some of those endemic mycoses or with autoimmune diseases. But it's not a one-to-one match, and you can have tuberculosis that presents with non-caseating granulomas. And in this case, on the repeat biopsies they did during the laparoscopy, it sounds like they did also see caseating and non-caseating granulomas. But you're right, there is still so much uncertainty, and so much of the testing for TB is coming back negative, like over and over and over again. There's all these AFB stains, and these are directly of the tissue that they sampled. They did AFB stains and cytology, that all looks negative. Um, it makes it really difficult because extra pulmonary TB can actually be really difficult to diagnose. And there's also this thing where with, I know for disseminated TB, actually a lot of times our sputum AFBs and our TB PCRs actually get worse at detecting TB if somebody has disseminated TB. Now, if it's just isolated to the abdomen, I'm not sure if that also holds true, but I've definitely seen I've seen a few cases where it's like every single test for TB was negative, and then the end diagnosis still ended up being TB. So I may be very well wrong here. So much of the data that we've collected that's, testing for TB has been negative, but she does have the non-caseating and non-caseating and caseating granulomas. Kind of just the story still just like feels like TB. And so if I were to hang my hat on some final diagnosis, I probably at this point still am thinking TB, and maybe I'm anchoring on this a little bit too much. But just keeping a broad differential on granulomas in general, what are some of the other things that cause granulomas? So infection. So I kind of think of the IMAID mnemonic, but then I remove E because it's not really endocrine stuff. But infections, especially those fungal infections, malignancies can cause it. Then autoimmune diseases, people mentioned sarcoid, inflammatory bowel disease that can also cause granulomas. And then D is your drug-related causes. So there's a few drugs. I'd have to look up which drugs are associated with granulomas, but that's kind of another cause. And then some more esoteric, rarer causes of granulomas would be like a foreign body, or I think there was one of the CVID, common variable immunodeficiency. So those are some esoteric causes, but kind of looking through that case, list of potential diagnoses, do we think this is an infection? I don't really feel like we've gotten much. Besides us thinking it's TB, I don't think I see anything that's telling me this is some kind of endemic mycosis or something. Malignancy, it still could be malignancy, but it's just the onset of her symptoms was so rapid. We have the positive IGRA for latent TB. So I just feel like I'm more leaning towards the infectious kind of TB side. And then autoimmune. So do we have any signs of sarcoid or IBD? She hasn't had any bloody bowel movements, hematochezia. She hasn't had hypercalcemia or anything in the lungs. The CT chest was normal. So some of those more common autoimmune conditions seem a little less likely. And then she's not taking any medications. So I can't say, unless she's taking some weird herbal medication that we weren't told about, I don't think we have any reason to think there's some drug related cause. So I think I'm still leaning mostly towards infectious for the cause of these granulomas and towards TB. But we'll see if I'm right on the final diagnosis. I'm a little nervous.
No, you're doing great. So before I reveal the diagnosis, I'm gonna launch a poll just so people can vote, and then before I reveal it. Yeah, so maybe almost 50% of the group think maybe this is TB, and the rest are interspersed between the other etiologies. So what happened in this case? So like you mentioned, that our differential diagnosis was very similar. We sent coccidiomycosis serology that were negative, Brucella, Bartonella, Coxiella serologies that were negative, syphilis was negative, fungal cultures remained negative from fluid. Serum crypto serologies were also negative. ANCA serologies were also negative. Uh, the After discussion with the infectious disease team, the negative ascites AFB and negative AFB stain are very insensitive for an immunopotent host, especially that in granuloma, the mycobacterial burden may be very low. So the best diagnostic test is, like you mentioned, is the omental AFB cultures, and the diagnosis was presumed TB peritonitis. So the patient was initiated on RIPE therapy and discharge for outpatient ID follow-up. The patient did actually really well with improvement in her abdominal swelling. They did resend the adenosine deaminase later on, and it was like markedly elevated, which confirms like the suspicion for tuberculosis. The AFB cultures never grew like tuberculosis, and and so the final diagnosis was TB peritonitis, exactly like you thought, Conan. Let me just share my screen quickly. I recently read this book by John Green, the famous author. He wrote The Fault in Our Stars, but the book is called Everything is Tuberculosis. But the book really highlights the inequalities as to the dissemination and distribution of TB around the world, and how common it is, and how we could make TB not common if we, as a humanity, invested in it, but we do not. So a few quotes from the book that I love is, "Nothing is so privileged as thinking as history belongs in the past." because we, like, for example, we live in a world with, oh, TB, that we don't see that, or that's only in the past. And then we notice that it's happening again. And we see that happening with measles right now. And the other thing is we know how to live in a world without TB, but we choose not to live in that world. So I highly recommend that book. And thank you so much for sharing your thoughts. So I'm throwing the mic to you, and Conan would love to hear your reflection.
Wow, what a great discussion and a great case, Yusuf. Thank you so much for sharing. And Dr. Lu, what an amazing like reasoning session with you. I really enjoyed every second of it. I would like to ask you for your thoughts and reflections that you had on this case, and maybe some like 2 to 3 teaching points that you have for us.
Yeah, yeah. Well, first of all, thank you so much for bringing such an excellent case, you guys and Yusuf. This is a really great case and just a great example of diagnostic uncertainty. And I do remember listening to an episode before, and it was like, if we were anywhere else in the world, if we were in India or China or somewhere else where TB is more common, they would have looked at this case, and within the first 5 seconds, they would have just said TB, right? I mean, the base rate, like I keep coming back to, but the rate of TB in those other parts of the world is so high that this is just like an automatic diagnosis for them. And we are lucky where we live is that, we don't see it as commonly. And so for us, we do think a lot more about all these other potential causes that could be going on here. And then again, this really goes to show you, the limited utility of certain tests. Like you can't hang your hat just on certain tests being positive or negative. You always have to look into whether or not they really have, good sensitivity or specificity for the specific scenario you're in. And so I learned something new. I learned quite a lot of new things actually. So knowing that the TB fluid, PCR, and AFB stains are relatively insensitive in acidic fluid. That was very helpful for me. And then also, just appreciating, because I was briefly looking at the chat at some points here, and just appreciating the brainstorm that like having multiple people thinking about a case together is just so helpful because there were so many great ideas that I think people threw out that I didn't even mention when I was discussing this case. So, some people mentioned lymphoma. People were mentioning getting the peritoneal biopsy pretty early pretty early on. And then, yeah, I think just really just keeping in mind your diagnosis and your differential for granulomas, and then knowing that it's not, you know, uh, cut and dry with the caseating versus non-caseating, and just really have a high suspicion for TB in these cases, because TB really can cause kind of anything, it can do whatever it wants to. So those are some of my points.
Well, thank you. I think Yusuf has to leave now. So thank you all for joining us today. It was such a great treat to have Dr. Lu here and Yusuf presenting a case. We'll see you again tomorrow. Thank you all.
All right, thank you.